and I'm a journalist with a very long-standing interest in healthcare and IT, and I'm absolutely delighted to be chairing this roundtable for Orion Health, where we're going to be talking about some of the big issues in the NHS, some of the big issues in shared care records, and some of the big issues for the future, and where technology is actually going to be going. I'm delighted to be able to introduce an outstanding panel of participants here, starting with Ian McCrae, who has told me that he wants to be described as founder and director of Orion Health and also odd job around the company, which doesn't do anything to convey his long-standing vision and commitment to using data to improve health and care, not just in his native New Zealand, but around the world, including here in the UK. We also have Colin Gray, VP EMEA Services, it says on my list, a senior health tech leader in the UK who's formerly been service director for Orion Health in the UK and Ireland, and really knows an awful lot about the NHS and has worked in it as well at UCL Partners. We have Sarah Hill, who is Supplier Engagement Lead, Commercial Shared Care Records at the NHS Transformation Directorate. So she's going to be bringing us some great national insight as to what's happening at the moment, and it also demonstrates how there's actually a very close working relationship between the NHS and suppliers in this kind of area. We have Astrid Fairclough, who is Programme Director for Wessex Care Record, so that's the Dorset Care Record and the Care and Health Information Exchange in Hampshire. I always have to remember not to call it the Hampshire Care Record because I live there. They're both Orion Health customers with a very rich record of shared care record development. And last but by no means least, we have Jane Owens, who's Digital Implementation Transformation Lead for Joined Up Care Derbyshire, which is one of Orion Health's newer customers, but big ambitions to catch up very quickly with other areas. So to provide a little bit of context for this debate and for people watching the video, the NHS has made a really significant investment in shared care records over the past few years. We've had some very early pioneers like Hampshire. We've had a local health and care records exemplar programme, better known for obvious reasons as the LICRA programme, which put a lot of money into it. And in September 21, we had a target for all of the new integrated care systems to have a shared care record in place, and NHS England is now laying out a roadmap for their development. For anyone who doesn't know what a shared care record is, it integrates data from the administrative and clinical systems that are used by hospitals, GPs, mental health and community providers, and increasingly social care. Extending care homes is a feature of the government's work in this space, and CHI has done a lot on it. And the challenge now, I think, is to make sure that ICSs can make the use of their investment to deliver on their remit, which is more integrated care, centred on the patient, making sure we can use the data they contain for planning and research. And Ian absolutely has lots and lots of thoughts on that and how it needs to be done. So the roundtable is going to look at a number of questions, and we're going to start by discussing how technology can support integrated care systems in addressing the current challenges of the NHS, because we all know it's under a lot of pressure. We've got waiting lists, we've got demand, we've got shortages of money, there's lots of problems. But the question, I think, is how can we address them by transforming our model of health and care? And Sarah, perhaps you could start by giving us a little flavour of the national picture as to where we are at the moment, and I gather some hot off the press tips for what's coming next.
Hello everybody, good to meet you all. I think in the past we've been criticised, as the NHS has been criticised, for not doing this type of work, and obviously coronavirus has really brought that to the forefront, especially in the shared record space. So there's been a lot of time, effort and money spent in trying to make that better for what you and I know as the patient, who's the person at the end. And because of that, a lot of technology has been developed in a very rapid space of time, which hopefully will help them eventually. Now we have the NHS app. So one of the future requests from Parliament is we need to make better use of that. And we can facilitate that by helping move forward with the digital space on a patient's care record. So it's not only visible to the person who can access that, but it is also available to the right people should they need help and care with their GP or wherever it is within the health system. So there was a programme that started 4 or 5 years ago where we as a NHS helped our local care records, I think that's what we would call them, they're now called something else, but it's all being developed as part of the new NHS moving forward. So we're being restructured, we're having better ways of doing things, we're supporting information and each other in being able to deliver that to the patient. The way forward, because we're reducing a lot in our numbers, we are looking at being better prepared, better communication across the NHS, and obviously in my particular little corner of the world, better relationships with our suppliers who help us facilitate providing that service to the patient. So the outlook for shared care records over the next 12, 24 months is to look at 5 particular areas. One of them is to actually say, what is our strategy for sharing of information? And that's not only shared care records, that's across NHS full stop. And that's been currently developed and looked at across the piece. We have a second one, which is one I think really key to shared care records, which is interoperability of systems. So how does that work? How can we facilitate that? How can we work better with not only our suppliers, but other people within our sections to facilitate different systems? You know, who thought 4 years ago we would have a cloud that we could store? You know, there's lots of different ways of using IT now, and there will be even more in 2 years' time. So it's continually looking at how we can make it better and develop it for the patient. The third one is something, what do we mean by you need to have a shared care record strategy for our people out in the ICSs? So that is looking at, if for instance we've got a really good system in Dorset, then how can we make, I don't know, Derbyshire better? And learning those lessons and also trying to make them all at the same standard, if you like. What does that mean? What is that standard? So we're looking at all of that in the background while all this is going on. And then the fourth one, another one dear to my heart, is convergence of our suppliers. What does that look like? Can we be better at partnering with them in order to move forward? Coming from the private sector, I don't think we talk enough to our suppliers. There's a big drive within NHSE to look at supplier relationship management and contract management and help facilitate, and work together better in order to achieve things. That's just generally, not only in shared care records. And then how do we sustain our shared care records? What does that look like in 2 years' time? And what will it look like in 5 years' time? So it's looking at all those 5 things in partnership with our suppliers to be able to help facilitate that.
Jane, what does it look like from where you're sitting? You're one of the newer shared care records, but as I said at the start, you've got some really big ambitions. So what are you looking to do, and particularly to address some of these challenges that we've got right now?
Yes, so there are quite a few challenges at the moment, and I think it's a case of prioritising them effectively. In Derbyshire, we do have quite an aggressive time frame and a timescale that we want to work to, because we're one of the newest shared care records, and I think it's important that we get the pace behind us to be able to come up to where other shared care records are. Given the fact that we know that they take time to gather the information together, because there's so many various ways that you can do it, API calls, etc., HL7 messaging, there's such a lot out there that you're having to accommodate. So it's an interesting one, but yes, today Derbyshire have signed off their end-of-life care proposal with Orion Health. That's something else that I feel really, really passionate about.
Tell us a little bit about that. What's that going to mean?
So what it will mean is that if somebody is end of life or has a long-term condition that's going to end up with their death, that for anybody that provides palliative care to that person, then what will happen is they will be able to access the Derbyshire Shared Care record. They'll be able to write into that record, press save, and basically then anybody else that is then treating that patient can see what's happened to that patient. But it goes deeper than that. It goes down to patient level. There are some very, very difficult conversations that need to be had for somebody that's end-of-life care. They're difficult for the patient, but they're difficult for the clinician as well. But to have an advanced care plan and to be able to record what your wishes are towards your end of life, make no bones about it, it is a wonderful thing. And I can tell you that from personal experience. I have got two close siblings, a brother and a sister that have long-term conditions. One lives 5 miles from the other in different counties. My sister has an EPAC record, and she takes a lot of comfort from the fact that she's been able to record how she wants to die and what sort of care she wants towards her end-of-life care. My brother, who has got exactly the same condition, is in a different county, has not got the option of an EPAC, and he spends a lot of time worrying about what's going to happen in his last days of life. So I don't think that we can underestimate that. But it's about making things better for the patient, but also making those conversations, those difficult conversations that clinicians have to have. We don't want to keep having those same conversations. I know my sister quite often says to me, I don't want people to keep asking me again and again, well, what do you want to do about this? What do you want to do about that? I want to live the rest of my life to the best of my abilities, not discussing what's going to happen. So I've been able to record it. The clinicians, when I meet with them, they can see exactly what I personally would like to happen to me. And then I can start to have some real good conversations with the clinician about what I would like to have as my care package in my latter days of life. So I don't think you can underestimate having an end-of-life care ability in a shared care record system. And when I say everybody can see them, I mean, anybody that has the right role-based access can access the record. So it could be social care, it could be healthcare, it could be somebody that's in a care home, and everything that happens to that person, it's relevant to their end-of-life care. So fabulous things. So really, really pleased that Derbyshire are embarking on that with Orion Health.
I think this brings us really neatly to the second question we wanted to talk about, which is how can we use this investment in shared care records and some of the technologies that go around them to make this shift, so citizens more at the centre of care, they're more active in their own health, they're active in their own well-being, and ultimately we can start shifting from just treating illness to promoting health as well. So Colin, this is probably a good moment to bring you and talk about some of the things that Orion Health is actually doing at the moment and has got in the pipeline.
Thanks very much, Lynn. Yes, shared care records never stay static. Everything's always progressing and moving forward. And aside from supporting all of our existing customers and their specific endeavours, we have a number of key developments in our shared care record pipeline for this year. I want to touch on our patient engagement platform as well, if I can too. But in particular regard to shared care records, we're working to add to the richness of the data that we store within that platform and how well that can be shared and leveraged for the ICSs in question. A key element of that is our strategy for GP Connect. We're just about to receive accreditation through our Devon customer actually for structured meds and allergies, which is going to obviously add value to that platform. We've recently completed an immunisation viewer that can be viewed and used within our shared care record too. Jane's already mentioned some of our read-write capability in terms of end-of-life care planning, and this is a real area that we want to focus on and extend. And having a palliative family member myself, I share Jane's passion for this. It's really important that this information can be shared once, viewed by everybody that's involved in the care of a patient. And I think this is a really exciting step forward for us with Derbyshire and making that a read-write shared care record and adding that value. I think some other specific areas where we are looking to extend upon and add to the detail that we currently have. It's really important that our shared care records include, sufficient data from social care and community settings as well. So that's one of our specific areas that we're working on in terms of adding more detail for social care records, and also making the data available, making the system available to different contexts as well. We have some great track record and referenceability with our Hampshire client, and Astrid will maybe touch on this later, about providing multi-factor authentication into the shared care record from care homes. So again, it's making best use of that data and information to support the care of the patient in the context in which that patient finds themselves. Sarah mentioned about the connectivity across shared care records as well, and that's one of our key fundamental things that we're looking at, is bidirectional data sharing using Firebase APIs and other methods, so that we have, even across different vendors and suppliers, we can share that data in a standards-based way and make that available. I think one of the key ways of leveraging and getting more benefit out of shared care records is also about understanding how they're used. So rather than talk about clinical data and its benefit, actually about the service management aspect of shared care records, who's using it, how's it performing, and that kind of data. We're also adding extra functionality around that, so that's more easily surfaced and visible through dashboards. So you can actually tell, is the usage of the system improving? Is it getting higher? In what areas? And so on and so forth. And I think that operational element's really important, understanding where your system is actually driving value. I think one of the really interesting things about Orion is that we're not just developing our shared care record platform. We obviously have two other strategic pillars within our business. We are driving our digital front door and patient engagement platforms, and also we have a new orchestral data analytics platform which supports ingestion of multiple types of data and use of AI and low-code development. So it's a very interesting development for us, which again should help us to leverage the value of the data that we have in our repositories. But quite interestingly, I saw some statistics last week actually from NHS England, which said that all the ICSs have a shared care record, which is what you would expect by now. But only 72 trusts across England had a patient engagement platform, and of those, maybe about less than a half were integrated with NHS app. And that's one of the key areas that we're looking at in terms of our own patient engagement platform. And we actually have a full digital front door solution that we can bring to bear where and when relevant. We actually have a very significant project across a province in Canada just now, which has been very exciting. It's very much an omni-channel strategy to engage with the population across that province, with a public-facing website, a whole range of a call centre facilities behind that, provision to the patient of access to their patient record using a patient engagement platform. And we're looking to add things like patient-submitted forms and surveys into that platform, remote patient monitoring, and a whole range of applications that can add value to the patient. And I think one of the key things is, one of the key things going forward, about making patients active in their own care is really about informing them, giving them the sense of control. They understand what services are available. And that very much aligns with, obviously, the national strategy and the NHS app.
It's interesting though, isn't it? Because in this country, we've heard about digital front doors. We were supposed to have one with the NHS app. Scotland's got its own version. And we've heard about them for quite a long time. This whole idea, let's join everything up. Let's give the patient access to their data. Let's make sure they can do all their transactions themselves. I've been at this a long time. 1998, information for health. So I think one of the interesting questions for this group is really, how do some of these ideas fit together? And also, why is it so hard to actually make progress in this sort of area? Because we have talked about, is it a tech problem? Is it an organisational problem? Is it an interoperability problem? What is it?
I think it's, I think it's a functionality problem. The patient engagement apps we've had so far haven't been very good. I mean, it's a bit like a banking app, which just it gives you the bank balance and you can't do too much more. The next generation of patient engagement apps will allow you to not only see your bank balance, but also do a whole lot of other transactions and things. And so a digital front door, which is a relatively modern, newish term. It allows you to have a consultation online, go into a waiting room, a whole lot of other functionality which traditional historic patient engagement apps haven't really done. So it's the next level. And the old goal is to do as many things as you possibly can remotely or via an app or a browser interface. And pretty much how the internet has revolutionised banking or air travel or whatever, this is what we need to do in healthcare.
Astrid, you're sort of in the foothills of this, aren't you? You're an early adopter for integration with the NHS app. How do you see things going?
It's interesting you say it like that, Ian, because much as I do agree, then you've got, how do you take the steps towards that point? And how do you progress when you want all of those things? And we have an environment where some apps, some portals have been adopted for specific conditions, for specific appointment scheduling, for specific virtual consultations. And for me, we've been using, we've termed it My DCR, which is My Dorset Care Record, and we piloted, and we're using that in a clinic context to try and get communication about a specific, about various conditions when somebody's under a care pathway. But everybody else has been doing lots of different things. And as you say, there haven't been many singular products that could do everything. And maybe we don't need one that can do everything, but what we do need is for them to all join together. That's an alternative approach. And I think with NHS App, we are hoping to make sure we can still play part of the game, because in the NHS, there are it feels like there are so many priorities. And we're working in bringing care records together and longitudinal health records and all of the terms that we say around shared care records. I have very little to do with appointment scheduling, but it is an absolute top priority for others in the NHS. And at the moment, there's a huge focus on that. And I understand, rightly so. So if we can work out a way so that we can work on working, that's a terrible sentence. If we can work out how we can use a way into all of these things that's simple for my mum and dad, for everybody who we all have patients, because we all are patients. So if we can work out a way that's simple, that is led by us as individuals living in this country, then hopefully shared care records can still be part of the PHR game whilst appointments are doing their things, whilst consultations are doing their things. So my hope is that our integration, which is coming so soon with NHS App, will mean that we can stay as part of that game, because there are so many different things coming along at the same time. And I don't want to do it one by one, really, if possible.
So the advantage I have over everybody else here is the best way to understand is what needed is to have a good health condition, like a good grade 4 cancer of the brain, which that's the way to actually really find out the failings of any health system. Or actually, alternatively, have a parent or a relative who has a serious condition, and you're trying to navigate the health system. And I tell you what, it's not easy. It is not easy. And so what you really want to have is one app. You don't want to go to multiple apps. You want to have your circle of care in there.
Yep.
And if you want to go and talk to the doctor or whoever, you want to click and communicate securely with that person, and so on and so forth. Have a consultation online. So again, as I said, it's not just using the banking analogy. It's not just looking at your bank balance. You want to do all the other things as well. And I think the starting point is you've got to pull together the medical record from all the different possible sources, put it together, which is what the shared care records do. It is the first step in improving healthcare.
I'm worried that if shared care records aren't alongside all of that work, then there will be such focus on other aspects like just appointment scheduling or just those different aspects that you're talking about, but it won't necessarily work so well because very many people have are going through an end of life pathway with diabetes. Of course they are. There's nothing simple.
Through a lot of digital front doors, aren't we? It's going to be rows of them.
We're
Do I
not
want the
simple,
appointment?
are we?
Do I want this?
Well, I think the real one of the because as a global company, we have a global perspective, and I think one of the real things which we're doing well in the NHS is combining the social services, the wraparound care, all the other things. Because healthcare is not just about managing your HbA1c for diabetics. There's a lot more to healthcare, and a lot of services you need aren't actually medical. And so I think it's one of the really good things you're doing here.
We've got a way to go though, haven't we?
It does feel a bit like an uphill climb at times, but then every step that you take, that's a positive. It's a real good feeling moment.
And because one thing that often comes up at this point in discussions is our clinicians and our patients actually up for it, because I pick up the Daily Mail and every time there's a suggestion of this, it's like, oh, well, my granny can't do it. So is there a health, what about the health literacy? What about the information curation? That's something you're very interested in, isn't it? How do we get people to see what they need to see and understand it?
We support them and talk to them, probably. And shared care records aren't necessarily going to be answering absolutely everything. We've got so many different efforts around, so we're part of, within the Dorset context, there's a big, lots of work around patient engagement and I don't know how to answer. Okay.
So it's about putting the patient first and putting them at the heart of it, rather than putting a system there at the heart of the care for the patient. Because we all know people that have unfortunately become ill or are ill, and but by human nature, we react differently to different types of treatment or different processes. And it's about saying to that person, what do you think will work for you? Because you do know yourself what you feel would work for you. But when you come into the health service or social care, and particularly mental health, because you could come into mental health on one pathway, but then there's so many more pathways that you've got to touch during your journey. But shared care records are about that joined up record. It's about giving that holistic picture to a clinician so that they're not spending the little precious time that they do have with their patients running over what they've already discussed elsewhere.
I think the other thing that shared care records will enable, apart from everybody seeing everything, is instead of a GP visit being the first stop in healthcare, so consequently the GPs are hugely overloaded, and now pharmacists can do a lot of things. In fact, some people believe that pharmacists can do up to 70% of what a physician might be able to do. also nurses, etc. So you want to take away from GP some of the mundane, simple stuff and have them working at the top of their licence.
Something Jane was just saying, and makes me think about that, is it's about anybody in the circle of care being able to do the right thing. When you were asking that, Lynn, that's where I was starting to think, and it can be the patient, it can be the pharmacist, it can be the nurse, it can be anybody.
It can be our mum ringing up going, Helen,
yes.
can you just do this?
Once we've worked out care access. Such a simple thing.
The circle of care is a really interesting concept because my wife was forever asking me things about my healthcare. I got sick of it. It would be a fantastic, I think some of the people here in the audience know Rosie. It would be a fantastic thing if she was able to go on and actually also contribute, view, contribute, arrange. So it's not just about giving the patient access, because sometimes the patients aren't in very good shape. So I think
it's also to save all of the people in the NHS system that are trying to help the patient time, not having to rush from A to B because actually they don't need to do that, so which is immeasurable. So when people are saying, oh yes, but it costs so much money and it's always pound notes, and that's what people are thinking about, actually there's a lot more to a shared care record in saving and helping the patient. So it's stopping, the lady shooting down the corridor to go and get somebody's maternity records, etc., etc. So that's a real demonstration of how it saves time and effort.
And you're quite correct what you're saying there, Sarah, but with somebody that's end of life, if they have made it known that they want to die at home and that's their preferred place of death, then quite often people that are in at home that are end of life, that suffer not being able to breathe properly, the first response of the carer is we need to call an ambulance. And it's actually going against what the patient or the person wants. But more importantly, it's putting added pressure on our ambulance service, which is already so overprescribed. It's about saving the time to enable the rest of the system to work efficiently.
And this brings us quite neatly to the third question that we were actually going to discuss, which is the role of shared care records in providing data, so that at a system level we can also start thinking about some of these things. How do we put perhaps in place some alternative services, or as you say, make sure that at end of life there isn't an ambulance called. And the question we were going to talk about here is how can we make sure that relevant, high quality and transparent data is available and useful for what's called population health management in the jargon, drawing up these initiatives that are going to help particular populations or individuals. I think there are plans, aren't there, to actually start joining up shared care records across the entire country. You were just start talking about that at the start, and I know Mark Hindle, who's the MD of Orion Health, is really keen on this. He sees this as just a fabulous resource, like a single longitudinal record for patients. Other systems can come and go, and that will stay there.
Yeah, but it's not easy. And, as my colleagues to my right have just articulated, it's a very complex, not one size fits all. But if we could get 80%, then that would be absolutely great. We then have to measure that up, but would the other 20% take us twice as long as the 80%? So there's a lot of work that's going on in the background to see what is the art of the possible. And I think touching on accessibility in the patient, it's also protecting those records. So it's thinking about the governance that needs to go behind that, their authority, saying, actually, I don't want that, and having that recorded. It's all of those sorts of things that we don't necessarily think about. It's a given. I said to somebody earlier, it's about, we all know what GDPR is now, don't we? We didn't 6-7 years, however many years ago it was. And actually you can give your authority for this, and it's a minimum amount. And you can give your authority for the next level. And that's what I think shared care records is like. So when you first talking about your front door is your first piece of information. It's very basic information. And then behind it, I almost think about it as a number of files. Behind that is, have you had an accident, etc., etc., etc. Have you got diabetes in your family? You know, do you wear glasses? All those sorts of things, but they're all connected in your medical record. But you don't need to see that all the time. It just needs to be able to pull in a particular situation, whichever relevant part of that it is. So you can literally have your front door and then behind it you've got all your pieces that go. And that's, you know, ultimately, that's what you would like. You know, we'd like to have optical records on shared care records. We'd like to have pharmacy records on That's blue sky, but actually it's entirely possible. But it's just looking at that and how we can facilitate that data sharing and what that looks like.
Ian, you've been a pioneer in using data and algorithms and how can we use it better? This is your topic, isn't it? Where do you see things
this is my happy place. Okay, so we start off with a shared care record, just doing lab results, radiology reports, maybe discharge summaries and a couple of other things. And that was quite a profound breakthrough because, well, historically, doctors didn't know what drugs the patient might have been prescribed or dispensed. And so this is quite a step forward. And now we've kept on going and adding more and more data to it. With heroic effort, we've tidied up that data. It is very difficult and time consuming. These records are now getting richer and richer and richer. We probably need to add social determinants to the medical records. We need to add, people want to add device data to the medical record. These records are getting richer and richer and richer, actually, and longer and longer and longer and harder to interpret and make sense of. So this is where I personally believe that ChatGPT, machine learning, has a huge potential, but there are problems as well as to where is the data kept, how do you make things secure. So it is early days, but in the medium term, I think that technology is going to make a big difference. Now, one of the features I would love to have as a qualified patient, one of the qualified patients in the room, I would love to have an ability to, when I go to this hospital, that facility, the forms that they ask me to fill out are already done for me, okay? So I'd love to see that feature added to the list. But the circular care, the transfer of information, I'm not convinced that you're going to be able to come up with a comprehensive way of transferring medical records from one region to another because they're getting increasingly complicated. You might be able to do a summary record, it's a possibility. But these records are going to get really, really big. Oh, by the way, I forgot, some people want to add the genomic variant data in there as well. I'm not quite sure of the utility, but sometimes there's some interesting stuff.
There is an exciting future, we can all sort of see it, but I know the panel have got some views on, we really need to get some basics right, don't we, to get to the sort of place that we're talking about. Astrid, I could see you nodding away when we were talking about things like data storage and standards. Where are we up to in standards?
I think we might have a shared care record that's been around for a little bit longer than Jane, but we may have started when there weren't quite so many standards around. So we've got other challenges about what we can do. We did a very pragmatic approach in various places, and that got us further faster. I'm very proud of it, but it leads to a challenge when you're trying to think about some of the next bits. Any of the next bits we've talked about so far, really, even with that machine learning, that really exciting area, some of the transfers, some of the pathway options. If you've been too pragmatic and you haven't got your strong foundations, it makes it really difficult. So we've also talked about competing priorities. We want the shared care records to do more and more and more, but sometimes we have to go back and rebuild on better standards. And that's a very difficult local challenge because we're not always great at, we're not great at saying, if we get asked, can you do this? And the answer is yes. But because we've found a way around the rules, not around the rules. If we get asked, can we do this? And we say yes, and it's because we've taken a very, a more pragmatic approach based on the standards that were available at the time, or not available, then we might have to redo it. But some of the assessment criteria doesn't necessarily allow you to explain how you've got there. And it really is tough to build in the ability to strengthen your foundations, to do new stuff at the same time, and to get funding for both of those aspects when one appears to get you further than the other. But it's without the foundations, we're not going to do any of the funding.
Jane, as a newer record, how are you thinking about your strong foundations?
So, yeah, you've got the standards, you've got the About Me standard, you've also got the MSV1 standard. There is a big issue at the moment with the maternity data set because it's huge. Maternity systems normally are standalone systems and they contain a huge amount of data, but not all of that data would you want to bring into a shared care record. So from my perspective, a shared care record has to be succinct. It has to be readable so that you're not giving the clinician something that's unmanageable to work with and becomes a beast almost. Because the more data you're putting in, you're feeding the beast. And what we need to do is we need to make sure that we're putting good quality data in that's up to date, it's timely, it's succinct, and it's relevant to what is happening with that person when they sit in front of the clinician, not something that happened to them 6 years ago. And I get where Astrid's coming from because there were no standards when you first started, and it does make it really, really difficult. But we have to get to the place whereby we have standards for these different data sets, because it will be so much easier then to plug the different care records together, because you're not having to do all this, well, it's in HL7 and we need to map it into whatever else to make it presentable in the records. But that's where I come from with standards. I think we really, really need to get to that place where there are health and social care standards.
And is this one of the strands of the interoperability work that's going on?
It's not one of the strands, but it crosses all of them, basically, because a lot of the standards that we have in place, we have foisted on our suppliers rather than talk to them about why it is necessary. And there's a new bill that's came out, I think it was in March or something, to do with IT. And I'm sorry I don't have it written down here, but it will put or impose on suppliers that you have to provide data at a certain level and standard, otherwise there will be repercussions to that. But I think actually all of our suppliers across our Share Care Records programme are very much aware of the standards, and we recently had a summit and that was one of the things that was raised. Could we just have some simplicity in that? And that is being looked at as part of the strategy. So we've asked several times, this is very complicated, could it be less onerous? And that would help our suppliers as well. And it's to do with, it then doesn't require perhaps potentially as much development work, which again is saving man hours. It's all of trying to think of all of those sort of things to get us to where we need to be.
We should say Orion Health has done a lot of work on standards and hackathons.
As a supplier, the problem I have is that you customers keep asking.
Yes,
you keep asking us to put more and more stuff into the shared care records, and it does make a lot of sense, and the standards don't exist. So here's only a problem. It's a problem all over the world, and so you can either try and write new standards, but I do think the way forward is, again, we're being asked to put in documents, discharge letters, etc., in text, and so with the approach we're moving towards, I believe others will move to it as well, is document tagging. So you can go through and tag the text and say, this patient has diabetes, doesn't have diabetes, you can do all sorts of negation. So that is the way forward. So I don't think the standards process is going to be able to keep up with what you guys are asking us for.
And I get where you're coming from there, Ian.
Because you've got social services, there's no standard for variant data, there's no standard for device data that I'm aware of.
But we talk about putting the patient at the centre of it. But when you are providing information for clinicians, then ask the clinicians what they need. Because if it's not any use to them, they're not going to use the shared care record. And that's the opposite to what we are trying to achieve. So you need clinical buy-in for anything to do with shared care records. Ask them. Even if there's not a standard, they will tell you what they want. And they may tell you that it's different depending on the service that they're working in, and that's where you get the complexities coming into it. But the one thing that I do like about the PRSB standards is they've already gone out and had those conversations with clinicians. They've spoken to other healthcare professionals, and that's what they've based the standard on. But we do need to get to that happy place.
I think we've got to do a lot more to accept each other's standards, because we do not need to reinvent the wheel 42 times.
No.
Now that we're all trying to reach the same place, and that worries me a lot, because we can just, as you say, PRSB are leading on the consultation side of things, but there is also a challenge around the development of the tech, I guess the tech side of the standards, because like you say, I think we're getting really strong on what needs to be included. And I think, interestingly, quite a few years ago, the LACRA programme was really strong on a lot of technical standards, but arguably they might have been not where we were all able to be at the time. And I don't know if we've gone back to technical standards.
So I think in the very early days, we had to massage data into SQL databases. And so standards were essential. The tech these days is the big data databases, the elastic searches, Spark. The technology is such that we can take actually less good data, in fact bad data, data with very noisy data with the odd signal here or there, and we can summarise that and pull it out and present to physicians the few things that are important. But there are some things where you definitely need to have solid standards, discharge summaries, obviously, lab results, radiology reports, etc., medications. But there is also lots of additional social determinants, etc.
I'm going to ask people to sum up. I think we've had a really interesting discussion over the last hour, and it would be very good to know what you all think we should be taking away from it. Is it the current challenges? Is it the exciting future? Is it, one particular bit about how we get there? Should we start with Colin? You haven't said very much since we...
Thanks, Lynn. I think the exciting part for me is that, this never stands still. It's a topic that's always evolving, and we're always an evolving partner in that. So it's exciting to me that, we continue to build on the data we have in our shared care records, and we're able to impart new and innovative ways of leveraging that data or making it available to the patients themselves. For me, I think what's really refreshing, and I'm not just saying this because I'm sitting next to the lady, but I think the supplier engagement with the NHS is really heading in a very positive direction, and we're very keen to deliver benefit to patients and clinicians, and we want to do that in as quick and as efficient a way as we can, and however we can work with all the parties involved to achieve that, I think is really important, through accreditation processes to achieve technical standards, or whether it's content standards via PRSB. We're really keen on really pushing forward on all of those fronts, and I think it's really exciting where we could get to if we continue to focus and double down on those things. So for me, that's what switches me on and gets me out of bed every morning, and clearly doing things like the end of life care planning with Jane in Derbyshire is the really deep and meaningful stuff that really benefits people at the worst possible times, and I think doing that kind of work, just reminds us of the why we're here. I think. So it's a privilege to work with Jane on work like that.
So,
Can't follow that.
try.
For me, I just think that any benefit that we can give to a patient, whatever situation they happen to be in, when they become poorly or they need help or support in any shape or form in their healthcare, is surely got to be good for the future of the NHS and therefore the patient. And you can see from our discussions that we've got real hopes and plans for the future, and hopefully what good looks like. We know it's going to be a real uphill battle, but you know, I agree with Colin, that's what gets you out of bed. And actually, I work with some great suppliers across this programme. So I feel fortunate because I haven't got any tricky ones, which is really nice. But I think part of that is relationship management as well, and you sharing and moving forward in partnership, because we can't do it without them.
Jane, you're nodding.
Yeah, and I absolutely agree with everything you said there, Sarah. It is great to have a relationship manager with the suppliers, but I've always very much worked on that be open and be transparent, and you're working in partnership, you're on a journey together. And when on that journey, you're not just taking a supplier and a shared care record, you're taking the clinicians with you, you are asking their advice, you are saying, what do you need to do your job to the best of your ability? How can we help you do that? And that is such an important thing to do. But most importantly as well is we learn lessons from other people. I mean, I constantly talk to Dorset, have you done this? Have you done that? You know, how have you done it? Because there are lessons out there. Dorset have done things that I haven't done yet because they've been going a lot longer than we have. So, you know, it's a journey that we're all on together, and we can create something truly wonderful if we just put our minds and our backs behind it.
And we're looking forward to learning from Derby about their end of life. It's a two-way process. We haven't progressed around that. For me, it's quite interesting, this conversation. I want to make sure that we're progressing across the three-ish areas. We've got foundation work that still needs to develop. We've got new stuff that the shared care record can do in effect on its own to a certain extent. You know, we can bring in drug and alcohol. We can bring in maternity information, stuff that we just know that using the shared care record in the way you use it will be more useful. So that's expansion within a fairly safe zone. And then we've got enabling different ways. And the more benefit we can save time on, the more space we've got in the ICSs to do the really, really exciting stuff. And that's changing people's work patterns, changing how patients are then able to get what they need. So for me, how do we balance those three aspects? And conversations like this help think through the three and make sure we're doing a bit of each.
Ian, paint the vision.
Hey, so with Derby being a brand new shared care record, you would hope they wouldn't make the same mistakes that the other ones. They'll just make a whole lot of different mistakes. Anyhow, new mistakes. But I do believe that healthcare is at a very interesting juncture, brought on to what I think was happening already, but COVID has brought it to a head. That I haven't found a health system around the world which says we've got this sorted, we've got it nailed. Everybody is has an acute shortage of primary care GPs, but I think the positive is that technology has advanced a lot in the last few decades, and can make a major contribution to helping deliver better healthcare. But I think first and foremost, you have to have the healthcare model, how you're going to organise your health system. That has to be sorted, and technology plays a supporting role in delivering better healthcare. And I do think that ultimately we've talked a lot about having patient-centred healthcare. It is not true. We haven't delivered that, but I think going forward, we do have the potential of doing that over the next decade. So exciting times for healthcare.
Brilliant. And hopefully exciting times for Orion Health, building on your shared care records and doing lots of exciting things with them as well. Thank you very much indeed, anyone who's been watching this debate. I hope you found that interesting, informative. If you would like to find out more about Orion Health, then of course do go and visit their website, and I'm sure people like Colin would be very happy to talk to you about any of the issues raised.